This video is about the Maya Kowalski case. First, a recap of the verdict.
The jury has awarded the Kowalski family more than $260 million in this medical malpractice lawsuit against All Children's Hospital, just hours ago, reacting to their victory outside the courthouse.
I mean, for the first time, I feel like I got justice.
After 8 weeks of testimony and evidence, All Children's Hospital is found liable on 7 claims, including false imprisonment, medical negligence, and wrongful death. The Kowalski family says the ruling sends a message.
Parents have rights, and they make the decision for their children.
The case has garnered national attention as the subject of a Netflix documentary. It depicts Maya Kowalski's battle with a rare disease and her family's experience at All Children's Hospital. Her mother, Beata Kowalski, was accused of Munchausen by proxy, medical child abuse, and doctor shopping. Maya, just 10 years old at the time, was separated from her family for 3 months. The family argues this prompted her mother to take her own life.
To me, it was about the answer, knowing that my mom was right. I want people to know that she wasn't harming me at all.
So why this video? This case has gained a lot of attention, virtually all against Johns Hopkins All Children's Hospital. And even though the verdict is in, I want to offer a different perspective, but also include information not already in videos on YouTube, including Beata's blog posts and emails. I will also show Dr. Kirkpatrick's assessment of Maya. Look at his links to Dr. Khan too. Look at what Dr. Chopra and Dr. Hanna said. Do deep dives into functional neurological disorders, complex regional pain syndrome, ketamine, Munchausen's by proxy, and medical child abuse. And at the end, I will look at what Johns Hopkins All Children's Hospital wanted to show to the jury, but were not allowed. And where to start? In their opening statement, the Kowalski's attorney said it all started on the day of a July 4th, 2015 parade.
This is a photo of the July 4th party. Maya started to feel a little bad. She apparently twisted her ankle in a gymnastics accident, or just from doing gymnastics, I guess. And then on the 4th, during all the festivities, Maya simply collapsed on the floor of the kitchen, and I think you'll hear Uncle Bob, her uncle, say she made a noise that no human child should make.
However, Beata kept a public blog. In this blog, she wrote as if she was Maya. A redacted version of the blog is available in the court records. This blog indicates that the July 4th, 2015 parade was not where it began, as Beata wrote about events that happened in June 2015. At that time, she seemed concerned about a cough that Maya had. This next section looks at June 2015 and what Beata said about Maya's cough in her blog to Dr. Kirkpatrick and to an immunologist. On June 16th, Beata wrote in her blog as if she was Maya. I seemed to be doing okay until about 4 p.m., when the cough started to get from bad to worse to out of control again. My mom had to drive me fast to Doctor's Hospital in Sarasota, asking my mom if I was going to die. The ER doctors tried desperately to help. Finally, the ER doc made a decision to transfer me by helicopter to All Children's Hospital in St. Pete. With the time passing fast, the air weather conditions became severe over Sarasota, and all flights became canceled. I ended up being transported by PAL's ambulance to All Children's Hospital. However, what the doctor wrote about this episode was, her lungs were clear with good air movement on arrival to Sarasota, and she was stable in room air. Asthma score was 0 at the time of admission. She was admitted to the short stay unit for observation, and she was discharged the next day. Beata also posted this photo of Maya, saying admitted with severe asthma attack. On June 24th, an immunologist and allergist then wrote she has quite the story of a severe asthma attack. But it sounds like a habit cough in a happy, well-appearing girl with normal lung sounds. Something doesn't fit here. Something is really not right. This is not just asthma. I wonder what role family dynamics are playing. The immunologist added, I was disappointed to hear that she ended up on a week of high-dose oral steroids the night she left here last week. I advised Mom not to use steroids as her pulse ox is above 94%. A recording of the cough was also played in court, and Beata can be heard telling Maya to stay strong.
And what are we going to hear now? This is the cough?
Correct.
All right.
Be strong.
I will be showing Dr. Kirkpatrick's full assessment of Maya later. His assessment videos are available on his YouTube channel. His videos of Maya were also not shown in court. In this clip, Beata is telling Dr. Kirkpatrick about Maya's asthma and how she treats it, including steroids and giving Maya Benadryl, sub-Q, which means subcutaneous, or below the skin, as well as Pulmicort, a steroid.
We got her on a team, and the team was 4 times a week.
I see. Great.
And that was very strenuous on her asthma.
Right, and that's another thing we talked about. She has what we call more than just average. She has a pretty severe case of asthma, right?
Yes, it's a cough variant asthma,
Okay.
which is rare,
Okay.
and it took us a while to determine what kind of asthma it was. But it's a cough variant asthma, and it's treated a little bit different than regular asthma.
So tell us briefly how it's different.
She doesn't.
By the way, this in case you want to share this with everybody needs to know you're a nurse. Okay.
I am a nurse.
You're an RN.
Yes.
So if you're using the big words, everybody kind of bear with you. Okay.
I will try not to.
No, that's okay. You're doing good. You're doing good.
So with the cough variant asthma, she hardly ever has any wheezing.
Okay.
Her asthma symptoms are cough, and the cough will get progressively worse.
I see.
To the point that it might be happening every 2 to 3 seconds.
Oh, really?
And at that point, that means it's really bad.
I see.
And we're trying to do everything to break that cycle.
Tell us how you try to break a cycle.
At this point, we're using Tussinex for the cough, Benadryl 10 mLs right away, Pulmicort.
And you give them how are you giving the Benadryl?
It's liquid.
Liquid. Okay.
Liquid 10
Orally.
mLs
Okay.
oral.
Okay.
And she has gotten it sub-Q when she was very severe. I have administered it sub-Q to her.
Okay.
And then we're starting, she gets 4 puffs of albuterol. So like the first 3 drugs are 4 puffs of albuterol, Benadryl 10 mLs, and Tussinex 2.5 mLs.
Right.
And then we do her Pulmicort or Duonap, depending on her symptoms. I kind of feel like the Duonap is working better, so I tend to give her the Duonap first.
Right.
And it's a nebulizer. She will get that, and that can be given every 8 hours as needed for her symptoms. And then she gets Pulmicort, which is once a day, but she can get up to 4 vials maximum if her symptoms do not subside.
Okay.
So as of right now, this regimen seems to work for her very well. She did have an asthma attack last week, which was brought by sinus infection.
Again, mostly cough, not wheezing. Is that
Correct.
correct? Yeah. Okay.
Correct.
Gotcha.
Wheezing is very rare, and
Okay.
it's very minor.
Yeah.
So she has lots of allergies. So allergies stimulate her asthma. She's got severe allergies to the environment, to the grass, to the trees, dogs, cats, severe allergies
Okay.
that bring up her asthma attacks.
Okay.
And she has, she gets sinus infections. She's got Ig selective immunodeficiency,
Right.
which make her less, her body doesn't fight as well the infections that
Right.
come upon her.
Right.
So with that being said, last week we had a really hard week, or maybe a week and a half, I should say, because she developed a sinus infection, which automatically led to asthma attacks and exacerbation of asthma. So she was treated with antibiotic for 10 days, and she was on asthma action plan for her asthma. And the first day of this episode was very severe. We thought we were going to wind up in a hospital again because it was very difficult to break the pattern.
Right.
But I did. I was successful. I stayed on top of it, and I broke the cycle.
Right. Now tell me, when she has the coughing going on, does she really get short of breath, or is it just a lot of
She gets short of breath. She gets throat tightness
throat tightness? Okay.
and shortness of
And
breath.
yeah, so what we talked about is 2 things. We said, I recommended that you have an internist take a look at her with the one question only. Is there anything we can do besides what you just described, which is very good, excellent? Is there anything else we can do to minimize her risk? Because she is at increased risk because of all this, okay? So, yeah, did you have a chance?
Yes, I have a chance to speak with her pulmonologist.
Okay.
And he stated that the regimen she is on right now should be sufficient.
Okay.
He feels that also ketamine does help with the cough variant asthma.
Yes.
So he said actually he is not worried about her as much.
Yeah, sure.
Dr. Kirkpatrick is asking about Maya's asthma and any risks when undergoing ketamine infusions. It is unclear which pulmonologist Beata is referring to when she says, and he feels that ketamine does help with the cough variant asthma. In these clips, an allergist and immunologist is giving evidence during the trial. He says that Beata told him about the ketamine infusions in December 2015, after they had taken place. He also speaks about his concerns.
So I was concerned about Munchausen by proxy at the time.
Okay, and why was that?
Because the symptoms, the physical examination, the objective tests that I've reviewed in medical records did not correlate with the story I was getting from home.
In what respect? Can you be more specific?
So there was a constant, the first is the numerous lower respiratory complaints, the asthma picture, the severe asthma. That was used a lot in a lot of the notes. Severe asthma, severe asthma, severe asthma. Like I said, in my experience, we have someone with severe asthma admitted to a hospital for a few days and comes out with normal breathing tests, completely normal spirometry. The lung doesn't work that way. I'm just being honest with you. When you get to a severe case, there are maybe some changes that take place within lung tissue. Your lungs will start over time sort of scarring within the bronchial tubes. That's why individuals that are not treated early on adequately will get worse over time. You can improve their ability to breathe with medications, but the breathing test was always going to show you some degree of changes in the lungs. There's always going to be there. I looked at the PFTs, the doctor from Old Children's, Dr. Kreisman, provided in his notes, and they were completely normal. So, and that was just one event. There were other severe asthma, and the most striking and most concerning was the numerous steroids utilized, both inhaled, oral, and in injectable forms in various ER visits, clinic visits, provider. And in fact, she actually had access to, I believe, to steroids at home that she could provide her at will. You have to look at the whole visit. There was a change from moaning and discomfort on the first visit to normalcy, which I thought was striking. The first time I get it, there was something wrong with it. That's why we requested records. The second time, it was complete opposite behaviors. Wheelchair bound, on a laptop, very happy, very distracted with whatever she was doing at the time. And I remember specifically, this is where it hit me, when I talked about how the workup that I had done did not prove immunodeficiency, and I wasn't aware of how I could explain everything else going on. And then she went into this phase of crying, and my ear hurt, and I have a headache. So after that was over, and I tried to find out what was wrong with her, and I tried to ask Mom, "Are you okay?" Then when the visit was over, as she's wheeled out to the waiting area, everything normal again. So you asked me about that narrow comment you made. I'm looking at a whole picture that led me to believe there's something not right about this.
So going back to the timeline, in June 2015, Beata had written in her blog that Maya had been coughing, that she feared she might die. And ER doctors had tried desperately to help her, including wanting to transfer her to another hospital by helicopter, whereas a doctor wrote her lungs were clear and asthma score 0. This next part describes what happened in July 2015. First, this is what a neighbor said about the 4th of July parade.
I want to take you back to July 3rd, 2015, the neighborhood bike parade. Now, either that evening or the next day, was there an event that occurred involving Maya Kowalski that was unusual from your perspective?
Etched in my brain forever. So it was actually the night, that evening after the bike parade, and we got back to Jack's house. The whole neighborhood was there. And as soon as I walked in, I heard what was it's a very difficult noise to describe. It sounded like almost gasping panic, but somebody being insanely hurt at the same time.
Did it sound like a child or sound like a animal?
It sounded like a kid. I almost thought it was a kid trying to make a terrifying noise. And I kind of chuckled like, what is that? And then I realized the look on these other adult faces was not not panic, but,
Was this the reaction
it
when
was a reaction of fear
bunch
of not knowing
parents-
what to do. And then I realized it was a child, so I figured this was not my business or my place. Something was going on that was pretty serious, and I just slowly backed out of the house.
On July 4th, Sarasota Memorial Hospital noted, "Last night she was getting worked up about the 4th of July, and when the fireworks began going off, she started having trouble breathing. Mom gave her prednisone and IM Benadryl with no resolve. Symptoms resolved on reevaluation, sitting comfortably in bed. IM means intramuscular, an injection into the muscle, and prednisone is a steroid. However, on July 6th, Beata and Jack took Maya to Johns Hopkins All Children's Hospital where she stayed until July 11th. Doctors noted, arrived in a wheelchair, has acute weakness. It is an unusual presentation. Habit, functional cough, discharge diagnosis, adrenal insufficiency secondary to chronic steroid use." On July 7th, Beata posted this photo on her blog saying Maya was unable to sit, stand, or walk. On July 17th, Maya was brought back to Johns Hopkins All Children's Hospital, and on this occasion, psychological pain conversion somatization was also noted. So what does conversion and somatization mean? This next section takes a deep dive into somatic symptom and related disorders. Somatic symptom and related disorders arise from a heightened awareness of various bodily sensations, which are combined with an inclination to interpret these sensations as indicative of medical illness. Terms like hypochondriasis are no longer used, as it is now recognized that the somatic symptoms and related disorders are much too complex to be given a catch-all phrase. A key requirement for diagnosing a somatic symptom disorder is that it must lead to significant distress or disruption in daily living. This helps to distinguish it from the occasional health concerns we all experience, even when there are no actual medical issues. Somatic symptom and related disorders can be categorized into two main groups, one where the symptoms arise unconsciously, and another where individuals intentionally fabricate their signs or symptoms through deception. The unconsciously produced set of disorders consist of a functional neurological symptom disorder and a somatic symptom disorder. The functional neurological symptom disorder is also sometimes referred to as a conversion disorder. I will look at the other side of the chart next. However, first I want to go into more detail about functional neurological or conversion disorders, as this was noted to be stated many times in relation to 10-year-old Maya. FND Australia have provided a useful overview of functional neurological disorders and the symptoms, causes, and treatments.
What are functional neurological disorders? Think of your brain like a computer. In this computer there is hardware, or cable work, and there is software. The brain software controls how your brain communicates with itself, with the outside world, and also the body. Functional neurological disorders, or FND, are like glitches of the software part of the brain. This can cause a variety of symptoms. Common problems in patients with FND are episodes of altered or loss of consciousness, which are called dissociative attacks. They can look like epileptic seizures, but are not due to abnormal electrical activity in the brain. Functional movement disorders can cause difficulty with walking, tremors, so uncontrollable shaking or weakness, and sometimes even whole body paralysis. There are other types of functional symptoms, including dizziness, sensory problems, speech disturbances, and cognitive symptoms. Literally every function that is controlled by the brain can be affected. It can even cause problems with bladder and bowel function. Functional neurological disorders are genuine disorders that cause real symptoms. The good news is that these disorders are treatable and many patients can improve. How are functional neurological disorders treated, and what is the prognosis? While there are no quick fixes for FND, it is possible to retrain the brain. Without treatment, many people don't improve, and some continue to be very disabled. Ideally, the treatment of functional neurological disorders is done through a multidisciplinary approach with input from neurology, psychiatry, psychology, and allied health professionals. With good multidisciplinary therapy, outcomes can be much better and many patients can get at least some improvement of their symptoms. It is important to know that there is no magic pill to cure FND, and generally, pharmacological or tablet therapy is not helpful in the treatment of FND. One situation where it can be beneficial is in treating high levels of depression or anxiety. A good understanding about what are the underlying mechanisms causing FND is very important. Generally, the approach to treatment in FND is to retrain the brain using automatic pathways in the nervous system. A combination of physical therapy and psychological therapy can be helpful for many patients.
I also found this explanation by Dr. Grunwald helpful, especially his analogy with a bungee jump.
So the model we have of the generation of these functional symptoms is that you have to consider the brain has two parts. There's the rational part of the brain that you do your thinking with, and you do your decision making with, and then there's an emotional bit. The emotional part of the brain will start to interfere with the way the rational bit works. The other thing that the emotional part of the brain can do is interfere with the link between willing movement, that is deciding you want to move, and executing movement. If you find that difficult to understand, I usually use the simile of, say, wanting to do a bungee jump. There are some people who decide they want to do a bungee jump and they'll go into the middle of the bridge and they'll get themselves kitted out with the highs, and then they find when they come to the jump that they just can't jump. They can't move, and they freeze. And however hard they try, however embarrassing it is that they can't do the jump, they just find they can't do it. And that's not because they're sick in any way, it's because the emotional part of the brain says, no, it's too dangerous, not doing that, and they can't do the jump. So in the same way, in these circumstances, the emotional part of the brain can actually stop people moving. It can interfere with that link between saying you want to move your arm and actually executing it. And that feels very odd. In the case of the bungee jump, you know deep down that it's fear that's stopping you doing the bungee jump. But when you have this underlying emotional disconnection caused by living through very difficult circumstances, you lose that ability to feel the emotion behind it. All you feel is that there's something stopping you moving. It feels as if you've forgotten how to move your limb. And that can be very disconcerting.
As well as functional limb weakness or paralysis, a person may have a functional tremor, functional dystonia, such as a fixed inverted ankle or clenched fist, or abnormal movements that look like seizures, called functional, dissociative, or non-epileptic seizures. These are also some clips from a talk by Professor John Stone, a consultant neurologist, who also co-authored a paper titled Complex Regional Pain Syndrome and Functional Neurological Disorders. Time for a reconciliation.
I wanted to just talk about some myths, because these are things I come across a lot in clinical practice when people think about the sort of patient I've shown you with that weak leg or someone with non-epileptic. They must have some sort of psychological problem or recent stress, because that's what we're told about conversion disorder, hysteria. There's they converted some sort of stress into their symptom. But for many patients, it's just not the case, and you can't detect a recent life event. And that's quite important when you're thinking about overlap with chronic pain, because one of the things that people often say is, well, my patient with chronic pain hasn't had a stressful event, or my patient with CRPS didn't have anything wrong with them before they got CRPS. Well, that's okay. That's the same as my patients with functional movement disorder, it turns out. Normal people don't get functional disorders. Well, it turns out they can. Psychogenic problems need psychotherapy. Psychotherapy is very important, psychological treatments. I'm not wanting to dismiss those, but I think we've come to a view in functional disorders that physiotherapy is just as important as psychological treatment, in the same way that you have in chronic pain. So DSM-5, we no longer need to have a recent stressful life event to have conversion disorder. And the other development that you might be interested in is that in ICD-11 there's going to be a category for functional disorders within the neurology section for the first time. So I think that quite correctly these disorders will be represented in both the neurological and psychiatric classification. If we forget about psychological and medical for a minute, what's really important is, do I have some sort of damage to my body that I can't do anything about? Or do I have the potential to get better? That's the key thing.
These are some clips posted by people on TikTok, where they show their experiences of functional neurological disorders and what can be achieved with the correct diagnosis and intervention.
So I don't think anything could have prepared me for the physical and emotional sort of roller coaster that you go on with functional neurological disorder. In the last week, I've been able to walk again, and then today I can't. So
can or cannot do, or can or cannot achieve. Just don't allow it. Just do not allow it.
I walked from the lounge to the den to show Gaynor because she's looked after me since I lost the feeling. I think she was pretty proud.
It's rewarding to see the progress made after the right diagnosis and treatments. On the other side of the chart, there is factitious disorder imposed on self, which is intentionally produced. A person with a diagnosis of factitious disorder imposed on self deliberately misrepresents their signs or symptoms and engages in deceptive actions, however, without any external motivation for doing so. This condition was formerly referred to as Munchausen's syndrome. It's essential to understand that this is distinct from Munchausen's syndrome by proxy, which I will cover later in the context of medical child abuse. In a factitious disorder imposed on self, a person may display symptoms that have been carefully investigated, with significant medical issues excluded. Nevertheless, they persist in claiming these symptoms, potentially motivated by a need for the care and attention that accompanies them. They often exaggerate and embellish their self-report. They might deliberately produce symptoms, forge medical records, or alter lab tests. Their medical background is usually quite extensive, and they often concentrate on a single health concern before moving on to another. However, they are not malingering. Malingering occurs when there are external incentives such as being given strong painkillers, avoiding criminal responsibility, or getting prolonged sick leave. Malingering is not a DSM-5 diagnosis, because it is not a mental health condition. A factitious disorder and malingering are not mutually exclusive. A person can shift between the two depending on the circumstances and reaction of others. What is clear is that somatic symptom disorders, such as somatization and FND, are genuine disorders, and the effective treatment is a multidisciplinary team approach, where everyone's aim is to help the patient feel better and get back to living life how they want to. On July 20, 2015, Johns Hopkins All Children's Hospital noted seen by physical therapy, occupational therapy. Parents declined neurological and psychological evaluation. Parents wanted her care transferred. Commercial air flight to Lurie Hospital in Chicago. It was also noted that Beata and Jack were adamant she would need a PICC line for transfer. This was deemed inappropriate and dangerous. A PICC line is a long, thin tube that's inserted through a vein in the arm and passed through to the larger veins near the heart. PICC lines can remain inserted for longer periods of time, which can be useful when a person is receiving long-term treatment, as they avoid having repeated needles inserted into their veins. Beata also posted these photos on her blog, showing that they were assisted by people from the fire department. At the trial, Maya's saying these were old colleagues of Jack's. Maya was then at Lurie's Children's Hospital between July 21st and July 24th. Beata posted this photo of Maya whilst there. Here, Dr. Revivo, Chief of Pediatric Rehabilitation Medicine at Lurie Hospital, speaks about some of their conclusions.
Current functional status, she is unable to sit up independently. Mom carries her to wheelchair in order to go to bathroom. Do you see that?
That's correct. I see that.
I note here in your physical examination, it says, quote, she is moaning and crying without tears. She stops moaning to answer questions. Do you see that?
I do.
What is the clinical significance of including those two sentences in a physical examination?
That allows us to create a picture of behavior and presentation. There's clearly a behavioral component to her pain, and this is how she's expressing her pain and her grief by presenting in this fashion.
Did you, after your assessment of Maya Kowalski, come up with an impression and recommendation for steps moving forward?
Yes. The fellow had written a decline in function attributed to conversion disorder. She has signs of pain, catastrophizing, anxiety, kinesiophobia. We determined that she would benefit from physical and occupational therapy, the psychological components, desensitization, and again, cognitive behavioral therapy.
Beata and Jack did take Maya to be included in Tampa General Hospital's rehabilitation program, and she was there between July 30th and August 27th. However, whilst Beata wrote in the blog, the PTOT staff at Tampa Gen was great. They worked very hard to get me better. She also wrote, I got tortured with pain during this process. I was told I wasn't trying hard enough. And lastly, the nurse practitioner, who was in charge of everyone, told me that the pain was in my head. We knew at that point that we had to leave TGH and get away from her, who appeared to us as she was practicing witchcraft, not nursing. The hospital also noted became hysterical before any activity was undertaken, deliberately putting feet in inverted position. They also noted Dad realizes that much of her behavior is filled with exaggeration. She was then discharged with a diagnosis of psychological factors affecting physical condition, suspected conversion disorder versus factitious disorder versus other. As noted earlier, conversion disorder is another term for a functional neurological disorder where symptoms are not intentionally produced, and a factitious disorder is where the symptoms are intentionally produced, however, for psychological reasons. This is a video of Maya at Tampa Bay Hospital at that time.
You can do it. You can do it. Move. Mom. Come on, ready? Yeah. There she goes. She's getting up. Hurry up. There she goes. Come on, giddy up. You gonna help right there? There we go. Okay, come on, left. Lefty, come on. Let's go. Come on, you did a break. You don't believe me? We'll do that. Let's go. Come on, left. There it is. That was great.
So between June and September 2015, Maya had been brought to 4 hospitals, some more than once. This also included a 6-day stay at Johns Hopkins All Children's Hospital, 4 days at Lurie's Hospital in Chicago, and 4 weeks at Tampa General Hospital. All reported diagnosis in the somatic symptom and related disorders category, however, with reports that Beata and Jack were vehemently opposed to this. It seems that Beata then learns about Jessica through Jessica's father. Jessica had been diagnosed with CRPS by Dr. Kirkpatrick. I will be telling Jessica's story later. However, first I want to look at what CRPS is and what it isn't. CRPS stands for Complex Regional Pain Syndrome. The first thing to note is that CRPS is a syndrome, not a disease. A syndrome is a collection of symptoms that go together but do not have a known cause. When the cause is identified, it is classified as a disease. With CRPS, for reasons not yet fully understood, some people get pain that continues beyond the normal time frame expected for healing. When this happens, it usually follows an injury or surgery. There are 2 types of CRPS. CRPS type 1 used to be called reflex sympathetic dystrophy, or RSD, and it accounts for about 90 to 95% of cases. CRPS type 2 is much rarer. It used to be called causalgia, and there is an identified lesion to a nerve. Because it is a syndrome and not a disease, there is no test for CRPS, and it is diagnosed on the basis of signs and symptoms alone. It cannot be diagnosed purely on the patient reporting symptoms. There must be objective signs at the time of evaluation, but as Pergolesi et al. Point out, even the objective signs are influenced by the clinician's subjective judgment. Clinicians may have varying interpretations of what they observe, which complicates the diagnostic process. This is further complicated by the absence of a laboratory test or similar method that can definitively confirm the presence of CRPS. CRPS is usually diagnosed using the Budapest criteria. These criteria are split into 4 categories: sensory, motor, pseudomotor, edema, and vasomotor. This video summarizes the criteria and includes photos. It starts by mentioning hyperalgesia and allodynia. With hyperalgesia, you feel more pain in response to things that are supposed to hurt. Whereas with allodynia, you feel pain in response to things that should not hurt. For example, pain from clothing touching your skin.
Basic diagnostic criteria for CRPS include, firstly, the presence of hyperalgesia and or allodynia. The presence of temperature and or skin color asymmetry. One foot is basically red compared to the other side, or blue. Presence of swelling and or sweating, which is one of the hallmarks of CRPS. Presence of loss of range of motion, very limited wrist or finger mobility or ankle and digit mobility. Presence of changes to the nail, hair, or skin. They will notice that their nails look frail and there's hair growth where they didn't have hair growth on that part of the body. Presence of weakness, tremor, and or dystonia, which is uncontrollable spasms. They have very much inability to contract the muscles of the limb.
Dr. Crane, a professor of anesthesiology and pain medicine, gave evidence at the trial. And these are some clips where he also describes CRPS.
So complex regional pain syndrome means what the words say. It's complex, it's complicated. It's regional in that it affects a region of the body. The frequency is not really known. It's probably on the order of 1 in 100,000 children that get this. So at some point in time, it can be days or a week or two after the injury occurs, the pain shifts from the pain of the injury, a twist or ankle or what have you, to what we call neuropathic pain, which is pain that has its origins in the nervous system. The pain moves to the surface of the limb, the skin, which has a burning quality. It becomes exquisitely sensitive to touch, even the lightest touch. The appearance of the skin can be very abnormal in CRPS. It can be very, very swollen. There can be color changes, as I said, deep purple skin. There can be blood vessel. It's hard to describe, almost like purple stripes on the skin. It can be mottled. So the lesions that occur because of poor blood flow to the skin, and something injures the skin and it just festers and grows from there.
Dr. Crane is also asked about the term whole body CRPS.
How many present with so-called whole body CRPS?
None. Nobody does.
And why is that?
Because, as I said, it starts in a limb. It's a regional pain syndrome. It can, in some cases, spread, and it does spread, but not right away, not early in the disease. Usually it's after months or actually more like years. It can affect the opposite limb. It can spread proximally. It can affect an arm. So it can spread, but it typically spreads to other limbs. It doesn't spread to other parts of the body. I can't say why that is, but that's certainly the case.
Here, Dr. Crane talks about treatments for CRPS.
What is the recognized treatment in your experience for pediatric complex regional pain syndrome?
The most important, the foundation of treatment, the kind of treatment without which it will not get better, is physical therapy and occupational therapy. A combination of physical therapy, occupational therapy, and psychotherapy by a qualified psychologist. Those are the fundamental things that will make it better. Everything else, we do other things, of course, but everything else that we do for CRPS, complex regional pain syndrome, is only useful in as much as it supports physical therapy and occupational therapy.
It is apparent that there is an overlap between the treatments for CRPS and a functional neurological disorder. That is, except for the use of pain medications. A functional neurological disorder is not treated with pain medication. If a person is wrongly diagnosed as having CRPS, when the diagnosis should be a functional neurological disorder, not only will they be denied effective treatment, but they can be harmed by being given the wrong treatment. And what about what CRPS isn't? For one, it is not the most painful condition a person can have. This is a myth circulating on social media. It was also stated in the trial. Here, the attorney for the Kowalskis is telling the jury about something he is calling the McGill Pain Scale.
Here, as you can see, this goes over, and this was developed in Australia. It's been around for a long, long time. It's adopted by about every hospital, every medical association. And this describes the different pain levels according to description by patients and every other objective finding that one can make. And you'll see at the top that CRPS is the most painful. It was actually developed at the University of Montreal, Canada by Dr. Waslasco, I guess, and most of the clinical trials were, I believe, in Australia.
Dr. Chopra is an anesthesiologist who gave evidence during the trial. Here he is speaking about the same chart.
What is the McGill Pain Scale?
The McGill University in Canada decided to see, like, okay, where do pain conditions stand? So they interviewed a bunch of people, and they said, all right, where in this scale would you put your pain? Like pain from labor or pain from amputation of a digit. And so they drew a scale, and that scale, CRPS was CRPS was way above anybody else. It was way above amputation pain, cancer pain, or even labor pain. If you go from the bottom, you can see, tension, headache, sprain, and so on. As you go up, then you see non-terminal cancer, chronic back pain, and as you keep going up, prepared childbirth is number 32, and then you keep going up, and then you come to amputation of a digit is 39, and then so forth, and then finally CRPS, often it was originally known as RSD, is rated as 46. So on a scale of 50, 0 to 50, CRPS is 46. Nothing is higher than that. It's such a terrible pain.
However, there is no McGill pain scale. The one presented in court was made by Invisible Illness Artwork. It is one of many circulating on social media. One giveaway on this one is that it states at the top rigorously tested scientifically scale. What there is a McGill pain questionnaire that is used to help people rate their levels of pain. It was developed by Ronald Melzack in 1975. He was based at McGill University and is known to have revolutionized the study and treatment of pain. His pain questionnaire is still widely used today. So where did that chart come from that has been labeled on social media as the McGill Pain Index? In 2011, an article published results of studies where the McGill Pain Questionnaire had been used. The authors of that article put the results onto a chart. Causalgia was at the top. Causalgia was the old term for CRPS type 2. That is when there is a lesion or injury to a nerve. It accounts for only 5 to 10% of CRPS. It seems that someone many years ago recreated the chart and replaced causalgia with CRPS, and the myth has grown from there. As can be seen on the chart from the research paper, CRPS, that is types 1 and 2, was about halfway. There are a few more things that Dr. Chopra said about CRPS that I would like to comment on. These are some clips.
And the worst part is that there's no known treatment to this. We try all sorts of things. Some work, some don't work, but this is this is often known as a suicide condition. CRPS is officially considered to be a rare condition, officially. But in reality, the incidence is actually very high. I have it here. It's about 200,000 cases per year, and the incidence is about 7% in children per year. It's officially considered rare because no one has gotten around to, because it gets missed all the time, so people haven't been able to accurately get figures as how many people actually have CRPS and was missed.
As already stated, there is no objective evidence that CRPS causes the worst pain a person can experience. Dr. Crane has also outlined what is well known about the effective treatment for CRPS. Dr. Chopra also states that it is known as the suicide disease. There are no studies saying that people with CRPS are at a higher rate of committing suicide than the average person. That myth may have started with a letter someone wrote to the New York Times in 1994. They wrote, "Privately knowledgeable doctors say that with advanced RSDS and chronic pain, patient suicide is common." RSDS was the old term for CRPS type 1. Whilst any chronic pain condition will impact on mental health, CRPS sufferers are not at a higher rate of committing suicide than average. However, it could be postulated that people who are wrongly diagnosed as having CRPS, when the correct diagnosis should be a somatic symptom disorder, may be at a higher risk of suicidal thoughts as they are not being given the right treatment. In this clip, Dr. Chopra also said, CRPS is officially considered to be a rare condition, but in reality, the incidence is actually very high. This is incorrect. As noted in Complex Regional Pain Syndrome, a clinician's guide, the incidence of CRPS in pediatric patients was estimated to be 1.58 per 100,000 in Minnesota and 5.2 per 100,000 in Netherlands. Taking either of these figures, the incidence of CRPS in children is only less than 0.1%. As stated before, there are strict criteria for a diagnosis of CRPS, and when applied properly, the numbers accurately reflect those with the syndrome. So, now we have covered CRPS. It's back to the timeline. On September 5th, Beata wrote to Jessica's mother telling her about Maya. She wrote, "She has dystonia and allodynia to her feet and legs. My gut feeling is that she has a neurological diagnosis, but no one has taken the time to do it correctly. I'd like to see Dr. Hannah." As will be seen later, Beata did take Maya to see Dr. Hannah, an anesthesiologist based in Florida with websites called NoPainHannah and IVKetamine.com. On September 15th, Beata then wrote to Jessica's mother saying, "I finally scheduled to see Dr. Hannah. I got the runaround. They told me he doesn't diagnose RSD. He only treats RSD, and I should see a different neuro and be referred to Hannah." Basically, it's a bunch of bullshit. On September 16th, Beata tells a pulmonologist, "Reflex sympathetic dystrophy is the most current diagnosis. This is the old term for CRPS. However, this had not yet been diagnosed." On September 20th, Beata posted on Jessica Stevens' Facebook page, along with this photo saying, "I'm a friend of your dad. I've just spoken to your mom, my daughter Maya. She's been unable to stand or walk since July 4th, 2015. She is sitting better and balance has improved, but her pain is still severe, along with fixed dystonia, spasms, and allodynia to her legs. We are going to see Dr. Kirkpatrick." So, who is Dr. Kirkpatrick? Dr. Kirkpatrick is an anesthesiologist based in Florida. He is not board certified. He provides ketamine infusions via a not-for-profit entity set up to conduct research into CRPS. People pay to take part in the research. This includes the ketamine infusions that he provides in Florida and the ketamine coma study in Mexico. Why Mexico? A ketamine coma study took place in Germany, and in 2006, Dr. Kirkpatrick is noted to have said, "I see between 200 and 300 new patients with RSD each year. I probably see more than anyone else in the world now. I've referred so many patients to Germany that it reached a point where I had to prove it to myself using our standard of scientific proof." When the German study concluded, Dr. Kirkpatrick proposed conducting a similar ketamine coma study in Florida, along with Dr. Schwartzman, who was involved in the German study, but it did not receive FDA approval. Subsequently, Dr. Kirkpatrick collaborated with Dr. Cantu. This 2007 article highlights how Dr. Cantu and Dr. Kirkpatrick decided to move the study to Mexico when they could not conduct it in the United States. To be eligible for this study, participants had to have severe and intractable CRPS and to have exhausted all reasonable treatment options, one being the ketamine infusions Dr. Kirkpatrick provided in Florida. Participants were responsible for their own funding. In 2007, the cost for the ketamine coma was $44,000. The German study into ketamine comas appears to have stopped around 2008, and since then it seems that the only person to offer ketamine comas has been Dr. Cantu in Mexico. Court papers in the Kowalski case also state that Dr. Kirkpatrick said he is a world-renowned expert in treating CRPS. I also note, however, that there are over 50 contributors to the main textbook, Complex Regional Pain Syndrome, a clinical guide, and he is not one of them. He is also not on the International Association for the Study of Pain Task Force that developed the Budapest criteria and its revisions. Dr. Norman Harden was on this task force, which is dedicated to ensuring that the Budapest criteria effectively distinguish between patients with CRPS and those without. In 2012, the task force highlighted findings from a study indicating that the diagnosis of CRPS was likely accurate in only about 40% of cases. While patients with CRPS were generally identified correctly, there was a significant number of false positives, meaning that individuals were incorrectly diagnosed as having CRPS when this was not the case. The criteria were updated at that time and have undergone further revisions by the task force, which recently convened in Valencia with Dr. Harden among the participants. These Budapest criteria are utilized by the World Health Organization, and they continue to be considered the gold standard for diagnosing CRPS. However, Dr. Kirkpatrick seems to have taken exception to the 2012 study, as evidenced by a video available on his public YouTube channel.
Recently, we contacted the Northwestern University in Chicago, indicating that one of their faculty members, Dr. Norman Harden, has published some data that contains errors and may even include fabrication of data. And making the distinction between a simple error and fabrication of data requires an independent review. We've asked for an independent review, and they have refused to do so. Therefore, we feel it's in the public's best interest for us at this time to make the data, the information available, and let the public decide for themselves the merits of the situation. And in particular, I would encourage the public to view a short video in which Dr. Harden testifies in court against a patient, stating that he does not have complex regional pain syndrome because he does not meet his mathematical formulation for the diagnosis. Dr. Harden would like his mathematical formula to be used internationally as a criteria for the diagnosis of RSD. This assumes that he's clinically competent to do so. Another factor here to be considered is that the individuals called upon to investigate this matter not only lacked the scientific expertise to judge this case, but because faculty rank is determined at a departmental level at which these individuals sit, they had a vested interest in protecting Dr. Harden in terms of his promotion to associate professor.
It seems evident that Dr. Kirkpatrick was not happy with the International Association for the Study of Pain's revision of the Budapest criteria, this video being from 2011. I wonder if this might account for him saying in a 2016 email, "The Budapest criteria are sometimes used for research studies, but not for clinical diagnosis of CRPS. The clinical diagnostic criteria for CRPS, published in 1994, are often used for the clinical diagnosis of CRPS." This email is in the court papers and was sent to Beata. This is incorrect. The Budapest criteria are the gold standard for the diagnosis of CRPS. They're not limited to research studies. If Dr. Kirkpatrick was using a version of the diagnostic criteria for CRPS, that was 20 years out of date. This may account for him being the first person to diagnose Maya with CRPS after many doctors had not. I also note the International Association for the Study of Pain Task Force to state in the recent guidelines on CRPS, high-dose ketamine coma is likely associated with very serious side effects and cannot be recommended. This may also be another reason why he seems dismissive of them. Dr. Kirkpatrick's comments regarding other doctors are not limited to Dr. Harden. In another email he wrote, "I caution Mr. Anderson about using Dr. Hanna as an expert in the case. In my opinion, an expert witness on the opposing side would destroy Hanna in seconds before a jury." Telling Dr. Sally Smith that he used high doses of ketamine in Maya's case secondary to tachyphylaxis is crazy shit. Tachyphylaxis is a rapidly diminishing response to successive doses of a drug, rendering it less effective. Dr. Kirkpatrick also gave his opinion about Dr. Chopra. Beata had written to Dr. Kirkpatrick saying that she was going to recommend Dr. Chopra as someone who could speak in court about CRPS. Dr. Kirkpatrick replied, stating, "Chopra will be biased to the degree that his scientific information on ketamine for CRPS on his website is outdated. He is so outdated that he refers to ketamine for CRPS as experimental and controversial." Before moving on to look at some of Dr. Kirkpatrick's assessments, I thought I would show some clips from a talk he gave in Cuba. Again, this is on his public YouTube channel. The first clips are from the trial, when he talked about how he can measure pain without talking to a person, using an algometer. He then shows his algometer to the doctors in Cuba.
One of the things I did since I started running the surgery center is I set up a new technology or a new methodology for measuring pain. I wanted to find a way so I could measure, without even talking to the patient, how much pain they're feeling between their earlobes.
And what did you use?
And what I used, I brought it today, I can show you if you want to see. It's a device called an algometer.
In these clips, he is demonstrating this to doctors in Cuba. I was struck by him referring to his algometer as being both approximate and precise.
So what we want to focus in on today is how to measure this pain. Okay. So when pressure turns to pain, we call that a pain threshold. You're going to say, stop. Okay, here it goes.
Yes.
Okay, what's that number? 3 to 25, would you say?
3, 5, 6, 7.
Probably about 325, approximately,
Yeah,
right?
approximately, yeah.
Okay, here we go, and here's another one.
Yes.
What's that number? 3.5, right?
A little bit more. 4, yeah.
3.5, approximately?
Yeah, 3.5, yes.
Okay,
yes, yes.
uno más.
3.5. Yes.
So that's approximately about 325, 325.
Yes.
So what does that mean? That means he's a bigger baby than you are. The point I want to make, if you look at this in terms of scientific measurements, that's pretty damn precise, okay?
In these clips, he talks about the ketamine infusions.
What I'm going to do is I'm going to give her ketamine, and basically I'm going to cut her head off. I'm going to cut her head off. There's going to be no signals going from here to the brain. How do we keep these patients safe? What we do is this. We want to make sure the brain is separated. We want to reboot the brain. When you have problems with your computer, Dr. Humberto, what do you do? What do you do when you can't figure out what's happening? Restart. Right. So that's what we're doing with the brain. The brain isn't any different, okay? It takes, what do they say, about half a watt to run the brain. It takes energy and it takes electricity to run the brain. So we're shutting the brain down and letting it come back up again, each time, over 4 days, okay? Repetitively, okay? So it's critically important, never ever do high-dose ketamine without having a significant other by the bedside. And by the way, doctors, let me tell you something. It takes a lot of workload off you. Guess who's measuring her cognitive function right now? It's not me. It's the father. It's the mother. That's less work for you, right? Less work for you. It means you can do other things with your time. Okay? All right. ¿Qué pasa? One of the things you saw, her salivate, okay? Especially in young people. You know, you've done kids with ketamine. You know, they just drool all over their face. So we have Robenal, what we call glycopyrrolate in the United States. You can give them a little of that, 0.2 milligrams IV. Takes care of that, and it's important to take care of it because it's uncomfortable when patients are salivating.
Do you use it?
Of course. Because if I don't use it, they salivate, okay?
Yes.
And it comes down on the floor.
Yeah.
And then you start sliding all over it.
Not so.
As well as his training video from Cuba, Dr. Kirkpatrick has many videos of his assessments on his YouTube channel. I have found them to be an interesting insight into how he conducts his assessments, as well as his understanding of diagnosis such as a conversion disorder, and what he tells patients about other doctors. In this first set of clips, he is assessing a young woman called Hannah. She is 19 years old when she first sees him in 2011. In this section, he is filming her before she has ketamine infusions for back pain that he is diagnosed as being caused by CRPS.
Complex regional pain syndrome originating from the back region is an extremely rare event. Often, these patients do not recognize spreading of complex regional pain syndrome from the back to other regions of the body.
2011. You're here from Texas. And Hannah, the first thing I want to do is kind of go over your history just a little bit, okay? Back in June 2011, you had a spinal tap done, or spinal puncture done. Anyway, make a long story short, as a result of that, it appears as though you developed some RSD in your back. Over the months, you started getting spreading over to that left shoulder of yours. And now, by my testing with your pain thresholds and so forth, and your own testing, we now think you've got it going into the left side of your face. And also we have it going into that left leg of yours down there, okay? Okay, the first thing I want you to do is it's called the vertical finger test. Look straight ahead, don't watch me. I'm gonna come over from your side, put 2 vertical fingers in your mouth, and I'm gonna ask you if you have pain when you do that.
No.
Okay, and I want you to take that right ankle and I want you to rotate it for me. Atta girl, good, good, good. Over here, rotate your ankle. A little bit more stiff, huh?
Yeah.
Wiggle your toes, please. So you're a very good candidate for the 3-day ketamine treatment.
The next video films Hannah after she has had ketamine infusions, beginning with her mother discussing how she feels that Hannah's appearance has changed.
And why don't we start with her appearance, her face?
Yeah, definitely a whole body, particularly a face, is a lot less swollen in just a very short amount of time.
Yep.
How about you, Hannah? Did you want to comment on how the experience was for you?
It was good.
I mean, you're not a cheap date. You know that. It takes a lot to knock you out. Was it worth it?
Yeah, definitely.
Quite an experience, isn't it?
Yeah.
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 Now you know why they call it tripping, right?
Yeah. Definitely.
Very good. Well, I expect you to do very well. Okay.
Yes.
And okay, very good.
In this next set of clips, Hannah has returned to see Dr. Kirkpatrick. Her mother says the CRPS has progressed to her legs, resulting in paralysis. Dr. Kirkpatrick agrees. He has titled this video series, "Do Some Doctors Torture CRPS Patients?"
This 2-part video series addresses an issue of great importance to patients with complex regional pain syndrome.
Do some doctors torture patients with complex regional pain syndrome? Part 1. Evaluation of the patient with complex regional pain syndrome who became paralyzed following surgery.
Okay, Hannah, today is June 18th, 2012. And what we want to do is kind of point out how you got here. We did a ketamine infusion on you, I think it was a 4-day? Was it 3-day?
It was 4 days.
4 days.
In October.
On October, which is approximately 7 months ago, something roughly in that range. And we found that we had some significant improvements in you. And it was documented on an objective basis, not only in terms of your pain thresholds, but also in terms of function. Then, shortly thereafter, we had the diagnosis of a gallbladder disorder, which meant clinically that your gallbladder needed to be removed. Okay? You go in to have the surgery, and then I'm going to turn it over here to your mom and tell us what happened at that point.
We followed the precautions that you suggested. We had her on 24 hours of low-dose ketamine infusion in a unit, and frustratingly, that
24 milligrams an hour.
No, we did 50 milligrams for 50 an hour for 24 hours.
50 milligrams an hour for 24 hours. Gotcha. Okay, which is a decent dose.
Yeah.
Okay.
And
not a high dose, but a decent dose. Go ahead.
Shortly after coming after that, even before leaving the unit, Hannah felt a sudden surge of pain under the incisions.
Point to that, Hannah. It's while your mom's talking. Go ahead.
Is it right here?
Right in there. Okay. Gotcha.
Which very rapidly spread to that right groin, and within hours, the whole of that right leg was numb to the touch, but exceedingly painful and had no movement at all.
Right. Okay.
We then saw that she got exceedingly unstable and was exhibiting all the signs of being in a seizure that she had no control over. And she would build up in intensity and then literally pass out unconscious. And then the searing pain in her leg would bring her awake, and the whole thing would rinse and repeat for hours on end until we could convince the hospital to get some Ativan into her. All of this was immediately diagnosed as a psychiatric conversion disorder.
We'll talk a little bit about what a conversion reaction is. By definition, a conversion reaction means you've got some kind of thing going on, usually a movement disorder. And of course, a seizure-like activity or movement disorder is a movement disorder, okay? But you can't explain it on an organic basis, okay? It doesn't follow the dermatones, the wiring in the body, and so forth. So a lot of times, what doctors fail to do, and which they did and failed to do in this particular situation, is try to link it to the organic problem that she has. And she was having the allodynia, she was having those things that suggest there was an exacerbation of her RSD because she was wounded. She got traumatized right there in her side, and that's what you would expect. But they didn't have enough knowledge, experience to realize that. So there was a logical, organic basis for a conversion reaction. Conversion reactions are things we see all the time in patients that are subject to extreme pain or emotional stress. And a good example of that is during the Japanese War, they took these prisoners of war, which were men, and they tied piano wires around their testicles and they pulled on them. Well, guess what? When they went to do that to these patients, it was such a stressful situation, they started having seizures, they would pass out, and all kinds of things. It's a protective mechanism, okay? When you're under extreme pain and extreme stress. So these doctors didn't have enough knowledge, enough skill. They just weren't competent enough to recognize that. And unfortunately, when doctors can't figure something out, it's easy for them to say it must be an emotional, it must be purely a psychological thing. And that's unfortunate. Instead of just saying, I don't know what you got, I don't understand it, but they put these labels on these patients, unfortunately. So that's what happened here. All right, go ahead.
We then struggled through a whole week of trying to get enough Ativan into Hannah to keep her stable, fighting this diagnosis, trying to convince them that we thought it was Hannah's RSD reactivating in a different part of her body, the original the original area being Hannah's back, triggered by a lumbar puncture in June of last year. And exactly a week later, the following Saturday, the surgery was done on a Friday, and the first leg went on the Saturday after we withdrew the ketamine. The following Saturday, it transferred to Hannah's other leg, again very quickly. She experienced searing pains up near her groin area, and it spread very rapidly down the whole length of her left leg. So at this point, a week after surgery, she had no movement in either leg.
Mm-hmm. Again, their leading diagnosis was a psychogenic conversion reaction. Am I correct on that?
Correct.
Now, let's turn to Hannah right now. Hannah, do you remember this, what she's talking about, these movement disorders that you had, this jerking and this looked like a seizure but really wasn't? Do you remember any of that?
Not really.
Right. And do you remember, did you have any control over it?
No.
Right. And this is another thing people need to understand, since we're talking about conversion reaction here. You can't control it. It's not something you can control.
Yeah.
It's out of your control, okay? And you're not even aware that it's going on. I want you to see if you can wiggle those toes for me at all. Just give it your best try. I don't see any action there. You getting anything? See if you can bring your knee off the ground here. Can you bring your knee off the bed? No, you can't even move it, can you? Now over here on your left side, again, the same thing. Let's do your toes first so you can wiggle those toes. A little bit of movement there, huh? Okay, very good. See if you can bring that knee off the bed a little bit. Can you do that? All right. And just to summarize, so they can't do it. So just to summarize, from your waist on down, you got allodynia throughout this whole area, correct? Mm-hmm. Real sensitive skin. Okay. Clearly what happened here, because I've just examined her, and I can tell you, this is all can be explained by an exacerbation of RSD. The decreased pain thresholds she has in the lower extremity, with the left being worse than the right, shows your allodynia. Shows your below this line, anything below this line is felt to her as if I'm tearing on your skin, right? Mm-hmm. We call that road burn sensation, okay? And as you can see, it correlates. Everything's correlating. You can see over here the allodynia is much worse on her right. Remember, it was on her back on the left side. Remember that? Now it's on her right side. And it's dominating down this side of her body. It's a quadrant disease, CRPS. It affects this part. And another thing we need to document here is she's got swelling. That's something we see with RSD, okay? And I did check her out down here. Her deep tendon reflexes are symmetrical, and they're good. I checked her Babinski's, and they're within normal limits, so we don't know, she doesn't have evidence of an upper motor neuron lesion like you might expect with Guillain-Barré or something like that.
Right.
So she doesn't, there's no evidence of that. So this looks like she's got the CRPS, and the conversion reaction is what any normal human being would do when they're put under extreme stress and extreme pain, and it's not something she has no control over whatsoever. We see this a lot in patients that have CRPS, okay?
Yeah.
You're not going to do a conversion reaction while I'm standing here. I'd like to get that documented. Just kidding. By the way, this is a PICC line they have in you right now, and it looks like it's not sutured in. It's so that's good news. We have to keep an eye on that, for any evidence of infection, that kind of thing. We talked about that risk, so we're gonna. And you're a nurse, so you know exactly what I'm talking about.
Yeah, you're looking after it.
Right.
Correctly so far.
Right, exactly.
I will continue the videos of Hannah next. However, it is noticeable to me that Dr. Kirkpatrick appears to not understand what a conversion disorder is, as defined by the DSM-5-TR, the diagnostic manual used worldwide. In the first edition of the DSM, published in 1952, the term conversion reaction was used. However, that term stopped being used in 1968. Then, the term hysterical neurosis was used. However, in 1980, this was changed to a conversion disorder, and now the term functional neurological disorder or conversion disorder is used. What is important to note is that none of these terms referred to physical pain as being the cause of the person's presentation. A conversion disorder is also not treated with ketamine. The treatment is provided by a multidisciplinary team, including psychologists, physical therapists, and occupational therapists. And members of that team would not accuse their patient of malingering, nor would they torture them. In this next part, Hannah has returned after her third ketamine infusion.
And each day we've been able to get you up to 200 milligrams a day. We can't do that with most people, but for you, we're able to do that because?
On an expensive date.
That's right. You're right. And what we want to do now, and we still got another infusion to go today, Friday. And then, of course, on Monday, which is 2 to 3 days later, we're going to repeat our measurements on you, okay? So let's take an interim look at you. You haven't been on ketamine since yesterday, so there's no ketamine around, okay? All right, let's start down here where things were really bad. Your worst was your right foot. And I want you to go ahead and rotate your ankle for me. Atta girl. Okay, good. Wiggle your toes for me. Okay, good, good. Now go ahead and bring your knee up as high as you can. Atta girl. Good, good. And I want you to do the other one. By the way, did you have any pain when you did that?
No.
Okay. Now do this one over here. Wiggle your toes. Good, good, good. I'm sorry. Rotate your ankle, best you can. Okay. Bring your knee up as best you can. You have any pain when you do that?
No.
Okay. Now one of the things, one of the conclusions we can draw right now from a scientific standpoint, this was all due to RSD.
Yeah.
It was all due to the surgery, which traumatized her. It's an injury, right?
Yeah.
Right?
Yeah.
And what the doctors down there said, this is all a psychological problem. This is a psychologically induced conversion reaction, right?
Yeah, versus malingering.
Malingering, right, which is not a diagnosis, that's an accusation, isn't it? So what we can do here is we can say, another conclusion, we can say this is RSD related, and all the doctors that gave all this false and misleading information, they're the ones that got a psychological problem, big time. Wouldn't you agree with me?
It's so frustrating because the last time I checked, malingering can't blow your feet up to twice the normal size, and literally Hannah's legs were paralyzed. When we got here, she had slight movement in 4 toes.
Right.
That was it.
Right, right, exactly. Okay, very good.
In this next part, Hannah returns after her 4th ketamine infusion. Dr. Kirkpatrick continues to talk about other doctors torturing patients by not giving them ketamine.
There are some doctors who actually torture patients that have CRPS. Now, if they're doing it intentionally, of course, that's a crime. But a lot of times, most of the time, it's unintentional, and it has to do with their ignorance. They don't know what they're doing. And when the stress is being generated by a doctor not giving you adequate pain control, as in my opinion what's going on here, it just adds to it. Now, there is evidence to support what I'm saying, not just the anecdotal thing I said earlier about tying, like in prisoners of war, tying piano wires to men's testicles and actually kicking them in the testicles, causing serious injury. There's now very solid evidence that if you stress a patient, particularly in torturing them, you can trigger a conversion reaction. And as you've learned, when we do something very specific to treat your pain, give you the ketamine, which I asked them to do, which they refused to do in the hospital. When I gave you the ketamine, all of this reversed. When you accuse a patient of making something up, feigning, malingering, that's not a diagnosis. It's an accusation.
They started to accuse me and Andrew and decided that we were reinforcing her symptoms, and suggested that if we stepped out, that her symptoms would improve when she has less stimulation and feedback. It's a big regret that Andrew and I did step out for that one night, because that was the worst night for Hannah, and in fact none of that happened, and yet they still disregarded what happened going forward. Her other leg converted and she was paralysed then in both legs after they had suggested that Andrew and I were somehow also responsible for causing this.
So the point is, when doctors are ignorant and they don't understand something, they always are looking around for some kind of excuse besides their own ignorance. Blame the mother, blame the husband.
I find it interesting that the person who diagnosed Maya with CRPS, that is Dr. Kirkpatrick, appears to believe that CRPS causes paralysis. However, Maya herself states otherwise.
Does CRPS involve paralysis?
No, it does not. There are some patients with pain so severe that they might not be able to move their limb, but that wasn't the case for me. I was still able to move my limbs. Obviously, I had my days, but I've never had paralysis. That's not associated with CRPS at all.
It's important to note, though, that this is Maya at 17 years old speaking, not the 9- and 10-year-old version of herself that we see here. going back to Hannah, another of Dr. Kirkpatrick's patients. In this last video, Hannah's mother talks about her becoming paralyzed again due to air pressure on the flight home. However, she then makes progress with pool exercises and is back walking.
And take it from, just give us a brief synopsis of how things have been going.
Yeah. We reversed the paralysis with a 4-day ketamine infusion and flew back to Dallas, and the plane ride itself seemed to reactivate the RSD. The pressure in the cabin was excruciating for Hannah. And
pressure changes due to flying high altitudes, right?
Yeah, absolutely. At that point, she then became unable to walk again because her feet had such bad dystonia that she was only able to walk on the outer edges of both feet, and that's when we came back.
Excuse me for 1 second, Hannah. Sure, just demonstrate how your feet. Yeah, see how they turn in. That's called inversion dystonia. Okay.
We have gradually upped the activity level and been consistent with the pool exercises for the past 4 weeks until she is at this point where we're still seeing consistent improvements, and her pain thresholds are now the best that they have been since first being injured with the lumbar puncture, and particularly since the paralysis.
Okay. Can I ask you a question?
Yeah.
Are you sure?
Yes.
Was it worth it?
Yeah.
Okay.
Sadly, I read that Hannah Waite died in 2014. These are extracts from news reports. She had been transferred to a long-term care facility after an extended stay at hospital. She had been prescribed a narcotic for chronic pain related to her pre-existing complex regional pain syndrome. She started to experience nausea and vomiting. The hospitalists attributed these symptoms to narcotic gastroparesis, a stomach disorder caused by pain medications. They administered anti-nausea medication, but it did not relieve her symptoms. 2 months later, she tragically passed away due to a severe erosive ulcer in her duodenum. The cause of death was later listed as intoxication by promethazine and hydromorphone. The news reports state that in 2017, her parents sued 2 of the long-term care facility doctors. Following a trial, in 2024, the parents were each awarded $15 million in damages for emotional pain and suffering. Of note, in November 2017, Dr. Kirkpatrick sent Beata an email, which was copied into Hannah's father, with a link to his videos of her just shown. He said to Beata, Tampa General Hospital refused to treat the young girl in this video with ketamine. As a result, the patient suffered a pulmonary embolism due to immobility and suffered unbearable pain until she died. However, according to the news reports, this was not the case. Hannah was not the only patient Dr. Kirkpatrick has said was paralyzed due to CRPS. In a 2011 newspaper article, Dr. Kirkpatrick was also quoted as saying, "This is a disease where we treat people who are quadriplegics because their body is shutting down and there is pain in all extremities. Patients like Fallon Mirsky are basically dying." Fallon's story is also very sad. The following is based on her blog posts. It seems that she was diagnosed with CRPS or RSD as it was known then. Dr. Kirkpatrick was providing her with ketamine infusions. In January 2014, she traveled to Mexico to meet Dr. Cantu and be assessed for the ketamine coma. Writing, "I will be undergoing the coma. It is a go." Well, it is a go as long as I can pay for it. However, she reported that it would cost $100,000. Fallon returned and tried to raise the money. In April 2014, she refers to a letter from a doctor saying she will die. It is unclear if this was from Dr. Kirkpatrick. She wrote, "Got home to receive a letter from one of my doctors, saying I am going to die and not make it much longer." Can you imagine a doctor mailing you such a thing? Like, "We aren't trying everything to get to Mexico. It isn't my fault money doesn't grow on trees." It seems that Fallon was having other significant health complications related to colon issues, and in 2016 she also wrote that they had found aortic vascular calcifications, and she might need a replacement heart valve. It was then reported that sadly, she died in 2021. Whilst Dr. Kirkpatrick said that Fallon Mirsky was dying due to CRPS, it is important to note that you cannot die from CRPS, as CRPS is only a syndrome, a collection of symptoms. It is not a disease. As will be seen later, Dr. Kirkpatrick said in an email to Beata that she should consult a hospice in relation to Maya. He also said that she would have a slow, painful death if she did not get the ketamine he provides. Sadly, Beata echoed this in a note to a judge. She wrote, "I hope you will take responsibility for my daughter's physical deconditioning, worsening of her CRPS, that eventually will lead to her slow, painful death. It is sad if Beata believed that CRPS can lead to death, as it can not. Next, I want to show one of Dr. Kirkpatrick's assessments of a child. The full videos are on his YouTube channel. Elizabeth is 11 years old.
Okay, Elizabeth, today is February 3rd, 2014. You're here for a 4-day ketamine infusion. You're from Utah. And I'm going to go over your history just a little bit here, okay? Back in October 2013, you had a tetanus shot done in that left shoulder area, correct?
Mm-hmm.
Initially, the pain was very isolated to that area, but subsequently, the pain has spread. And in fact, the way it spread is the really sensitive skin. In fact, you still have some very sensitive skin down here in your feet, okay? All right, remember the vertical finger test? Take 2 vertical fingers, put it in your mouth, please. Atta girl. Good. You have any pain when you do that? Okay, good job. Now, the next thing I want you to do here, Elizabeth, this is the part that requires a little bit more of a challenge for you. I want you to start up here on your leg, okay, and I want you to work your way down. Remember how I showed you? Nice, light strokes like that. Close your eyes. And when you get to the area in that leg where it feels like road burn, remember the road burn signal, just stop and point with your finger. Okay, go ahead. Get started. There you go. Go on down. Atta girl. Good job. Let us know when you get to that road burn. You hit it right on the nose, girl, right on the nose. Okay, very good. And of course, you're going to have the same problem on the other side. Go ahead and do that just for your own satisfaction. Go ahead. Work on down. Atta girl. When you get to that area that feels like road burn, just stop. Right, there you go. Good job. Next thing I want you to do is I want you to rotate that right ankle for me. Atta girl. Wiggle your toes. Hitchhike back to Utah. All right, good job. Good job. You might make it. All right, you have any pain or soreness or anything like that when you did that? And where did you feel the soreness?
It's just like in my ankle.
In your ankle? Okay. All right. Very good. Now do the same thing on the other side, please. Rotate and then wiggle your toes. Wiggle your toes. Hitchhike back to Utah. There you go. Good job. Okay. Very good. And again, the same soreness in your ankle when you do that? Okay. Good job. Now the next thing we're going to do here is we want to see what you can do. You cannot weight bear safely. Okay. We know that. But what I want you to do, you see where your mom's sitting? She's going to get out of that chair and she's going to spot you to make sure it's safe. And I want to see what you can do on your own and transferring yourself as much as you can on your own from that chair over to the wheelchair. I'm going to ask you to relax for a while you're there, and then I'm going to ask you to transfer yourself back to the chair, okay? Okay, Mom's there to watch to make sure you don't injure yourself, okay? Do as much as you can on your own. Mom is watching you. Atta girl. Good job. All right, very good. Good job, good job. Now, okay, let me know when you're ready to go back to the chair, okay? Let me know when you're ready. Take your time, take your time. Catching your breath, aren't you? It's all right, don't rush, no rush. That's quite a little jump you did there. Take your time. Atta girl. All right. Your mom's there to be for safety, okay? There you go. Good job, Elizabeth. Good job. Good job.
She had had injuries from downs before, but nothing has ever stopped this kid.
Right.
Until October 1st, when she had the tetanus booster shot, and life dramatically started to change and turn, and she stopped.
Right.
Life stopped for her.
Right. Elizabeth, did your mom pretty much tell it like it is?
Mm-hmm.
Do you have anything to add to that story?
Not really.
Okay, no, that's fine. That's fine. Now, let me ask you a question here, Elizabeth. You know a little bit about what we're going to do, right? About the ketamine. Do you have any issues, concerns that you want to talk about? Any questions you have? Please, anything at all. Anything.
What hurt me?
In other words, would you feel any pain during it? The only thing, to be perfectly honest with you, we have to start an IV on you. I'm going to put it in. I'm going to be as gentle as I can, okay? But we do need to get an IV started, okay? All right. Other than that, it's pretty smooth sailing. Okay. Elizabeth, I want you to look over here at Grandma. Grandma has some questions for you.
Grandma.
Here's Grandma. Here's Grandma over here.
Hi, Elizabeth.
She has some questions. She has some questions for you. Go ahead, Grandma.
Elizabeth, what state do you live in?
Utah.
Look over there. See Karen?
Hi, Elizabeth. Hi.
Karen's got a question for you, okay? Go ahead.
Okay, I noticed that Dr. Kirkpatrick has purple teeth today. Can you tell me what I noticed about Dr. Kirkpatrick? What did I notice about Dr. Kirkpatrick?
Go ahead and ask her another question.
Okay. I noticed that your grandmother is wearing a pink tutu. What did I notice about your grandmother? Do you remember what I noticed about your grandmother?
Elizabeth.
It's okay.
Elizabeth, can you answer Karen's question? She asked you a question. Do you remember the question? One more and that's it. Ask her one more question.
Okay. I noticed that there's a green lizard outside. Can you tell me what I noticed was outside?
Green lizard.
A green lizard? Yeah, you got that one right. That's right. Okay. Now listen, here. I wanted to see if you can cooperate with me a little bit here. Elizabeth, you see my finger up here? Look up there. Atta girl. Good job, Elizabeth. Over here. Look over here. Atta girl. Good job, Elizabeth. Now I got one more question for you. Are you ready for this? Are you ready? Are you ready? Okay, that's a yes. Show me the sign, Elizabeth. Let me see the sign. Get that blanket out of the way. There's one. Where's the other one? Where's the other sign?
Show him the sign.
Show me.
Show him the sign.
Show me the sign.
Show him the sign.
Can you show me the sign? All right, that's close enough. You're doing a good job, Elizabeth. Okay, so today is February 11, 2014, and your last ketamine infusion was on a Saturday. And so now we're about 2 to 3 days beyond that point. Let's talk about how things went during the infusion itself, okay? During the infusion, we tried to get you higher than 90 milligrams an hour. We couldn't do that. It just seemed like you were getting a little too agitated, that sort of thing. So we got you up, but you're 11 years old, so I was very happy with the dose we gave you. Because when you look at the video we did when you were given ketamine, you were pretty knocked out, right? And that's good. So it tells you that in order for ketamine to do you any good, you have to really shut the brain down, okay? Now, we remember before we started, give me your foot here. Before we started with you, I could just barely touch her like this, barely touch her like that, and you go through the roof. Remember that? Now we can do this. You don't have the sensitivity. We take your foot up like this. We can touch it, right? Like this. Doesn't drive you crazy, does it? So, so we know that this has had a big impact, and it's even hanging in there now. It's 2 to 3 days later, and I expect it to continue to do so. Let's go through these exercises. Make sure Dr. Kirkpatrick didn't create any new problems. You ready? 2 vertical fingers in your mouth. You have any pain when you do that? You didn't have it when you started. You don't have any now. I want you to take that right ankle. I want you to rotate it for me, okay? There you go. And wiggle your toes. Remember, when we asked you to transfer from the chair to the wheelchair and back and forth, you had a problem with that. And you couldn't even let your feet touch anything. Do you remember that? Let's see what you can do now. Atta girl. There you go. Take your time. Use your arms. Atta girl. That's it. See, now you're putting your feet on the ground, aren't you? You're not ready for full weight bearing, okay? And if you try to do that, there's a chance you're going to re-injure yourself very bad, okay? It's going to take a good 4 or 6 months to get you built back up again, okay? But, at first she didn't want to complete it, did she? She didn't want to complete it.
She was adamant about not completing it. It was a scary experience for her.
Yeah. And we got her up to 90 milligrams an hour, which is an adequate dose, as we know, to treat her problem, okay? Right. Or anything else that concerned you?
No concerns. In fact, midway through the second infusion, I was comforted when she told me that the burning pain was all gone.
Yeah.
As she was trying to pull out her IV, I'm done. She says
right.
no.
Right.
It was emotional. It was hard.
Yeah.
But it was a very positive experience, especially compared to the last 4 months and 4 days that. Yeah. This took a toll on her life. It stopped.
Exactly.
Well, and I think it's interesting to note that the CRSP, the RSD, actually changed her ability to work with us. She didn't used to be combative and refusing to do things like a 2-year-old like that.
She became very 2-year-old-like behavior. You couldn't reason with her. You couldn't talk to her. And that started the minute the RSD started. Yeah. It was like I couldn't reach her. It was why I think a lot of doctors thought that this was psychological based and not anything else.
Right.
Because it really triggered an emotional component in her, along with everything else, where you couldn't reason with her to even do the infusion.
Yeah, that's a very good point. You're making a very good point, and that is, it's not their fault. It's just that they can become so overwhelmed from the stress of the pain, they can't think straight.
That's right.
They just can't.
School stops everything.
And let me tell you another thing that can happen, and this is really, really important. It didn't happen to her, but I'm telling you, I've seen it more than once. Many times I've seen it in kids. Not so much in adults, but in kids. And what happens is the stress from the pain becomes so severe that there is a protective mechanism that sets in. We call that a conversion reaction. And what that is their legs can become paralyzed. They can't move. They may even lose their ability to feel things in their legs. And sometimes the parents will take advantage of that, clip their nails, clean their skin or something. So again, that's another thing that if doctors don't understand those problems that happen, that are part of being a human being, I mean a child, they don't understand that thing. Again, they can accuse the child of having more of an emotional problem than a real organic problem. Sometimes they can go blind, they can't see, but you can take them to ophthalmologists, there's nothing wrong with their eyes. Okay? All right, so all of these things are called conversion reactions. So I've seen that a lot in kids. So these kids, they need to be seen at by specialists that know some of these things that can happen, okay?
Okay.
And because they can be very terrifying. So yeah, the stress makes it extremely difficult to communicate with them when they're in such pain. You notice now how more communicative she is.
Yeah,
she's paying attention, she's learning, she's asking questions.
Do you think dancing is something she's ever going to be able to do again?
No, I think dancing is fine. There's different types of dancing which are safer than others, okay?
So just not the high competitive stuff that she
loves? The stuff
loves.
where there's a lot of risk of trauma.
Right.
Blows and trauma, a lot of shocking to the knees and the ankles and stuff like that.
So no more competitive dancing.
Yeah.
Just more mild.
Not for the time being. And that can be very creative and requires a similar kind of skills, except you're just not exposing yourself to all those high risks. Right. She did a good job, right?
Yes.
So let's
You too. You were incredible with her.
Yeah,
you gave her that grandpa Nell figure talking to, and she needed it.
Did I kick your butt?
We appreciated it.
No problem. So today is April 8th, 2014, and it's now approximately 2 months since your ketamine infusion, your 4-day ketamine infusion, okay? And before we go any further, we got to make sure we know where everybody that's here. Okay, here's Mom, and here's you, the patient. And here we have, what is your name now?
Bella.
Ella?
Bella.
Oh, Bella. I'm sorry, Bella. And how old are you?
9.
And you're the sister, right? And so back in October of 2013, you had a flu shot into that left shoulder area, right? It was a tetanus booster, right?
Yeah.
And you ended up getting real sensitive skin there. As a matter of fact, your whole body became sensitive to light touch, right? Mm-hmm. And then it seemed to settle down into your legs, right? Down into your feet. And in fact, you couldn't even walk, okay? You were unable to walk, which is terrible to be 11 years old and can't walk. And so, so you came here, we made the diagnosis of you have this complex regional pain syndrome. And so we decided to go ahead with this 4-hour a day for 4 consecutive days of the ketamine. And we're talking now about the ketamine being given as conscious sedation. In other words, not to put her in a coma, but it's what we call sub-anesthetic ketamine, okay, 4 days. Okay, we did your pain thresholds, and your pain thresholds demonstrated a profound improvement in your pain. Okay, that was an objective measurement. And also at that time, you could walk for the first time where you couldn't walk before. And we're going to show a little video clip here where in fact, the only way you could transfer yourself from that chair to that chair is to crawl from one to the other. Am I correct on that?
Yeah.
All right. Okay, very good. Now, so let's go ahead and run you through the usual exercise program here. So go ahead and put 2 vertical fingers in your mouth, see if you have any pain. Any pain when you do that? Okay, no pain when you started either. And go ahead and rub your hands down there and see if you have any more of that sensitivity down there. There's a black line down there where you had it before, where it felt like road burn, right? You don't feel that anymore, right? Take 3 steps forward, please. Add a girl, 3 steps back, add a girl. 1, 2, 3. Did you have any pain when you did that? Let's talk about a few things that happened during the infusion. For one thing, there was one point or 2 points or occasions in which you really wanted to almost give up on it, right? Because you felt uncomfortable, right? Now, when you look back... Yeah, right.
It kind of feels like
so,
down in a black hole.
Down in a black hole, that's right, that's right. So that, again, we're using this for educational purposes. It's important for people to understand that's very critical in terms of making the ketamine work, is you have to be comfortable, okay? That's really important. Now, the other thing we want to talk about is that before you had when you had the CRPS, starting in October of last year, you were very sensitive to sounds. You remember that? And has that improved?
A little bit. I still am pretty sensitive to
Yeah,
it,
but not as much. Okay.
One of the biggest things that I'd say I've noticed is when I look at her, I see my daughter again. She's happy, she's bubbly, but the swelling in her face, and I'd say the swelling in her entire body has gone down, but you notice it more in her face. She's got her cute little thin face instead of it being puffy, and she sparkles again. Look at those beautiful eyes and how they sparkle.
Yeah, and she likes to kick my, you know what? She's getting sassy, you know, right?
She's very sassy. That's my little girl.
Yeah. Don't you stick your tongue at me again. Yeah, that's true. And as a matter of fact, if you look at the photographs that we took, and we'll put those up so people can see it, you'll see there's clearly a decrease in this puffiness in her face after we treated her with ketamine, and she's continued to lose that puffiness in her face. Okay, and so a lot of these things that her kind of I can't think of a better word to describe, kind of a cocky attitude that she had before. That's fair, right? Isn't it? Sort of.
A little bit.
That we can understand when children are afflicted with something like this, it can really make them very irritable, extremely irritable. Do you agree with me?
Yes.
You find the irritability is improved on her?
Oh yeah.
Less of a short fuse?
The irritability has definitely improved. She's got her attitude back.
Yeah.
What does that word mean? I said, she's back.
Yeah, she is. I know I had a difficult time, communicating with her before all this happened. We all did.
Nobody could talk to her. She didn't want to talk. She was so focused on trying to focus on whatever she needed to try to beat the pain. Don't ask me a question. Don't ask me how I feel. Don't touch me. Don't come near me. Don't even breathe next to my foot, especially. Right. That's true. You would accidentally bump the bottom of her foot, one of her sisters. And she would immediately, her pain levels would go up so high to where it would throw her into these convulsions. She'd get scary. She would stop breathing.
Right.
And now you can, look at this. Let me see your foot. Look what I can do to it now. I can just, this.
Yeah. The other thing, another question that came up, you asked earlier, what about if she, later in life, what about having babies and that sort of thing? As far as we know, patients, that's not a problem. As a matter of fact, most of the patients that have had ketamine or CRPS, their symptoms usually decrease during pregnancy, okay?
Okay.
So there's something about being pregnant that is nothing to worry about. There are some precautions that should be taken, but it's not something to really worry about.
Okay. And then just the popping of her joints?
Yeah, no, I'm not too worried about that, and I don't think you should either, except to suggest you get some earplugs, okay?
Yes.
All right.
It's like nails going down a chalkboard. It's terrible.
Right.
She has a question for you.
What's that?
Will I be able to dance and do gymnastics competitively again?
What did I say? What did I tell you? Don't get involved right now in any high-risk injury things, okay?
Yeah, but
later, once you build yourself back up again, then you can think about it, right? But not now. That's the most common reason, that by far, the most common reason why people go out of remission is re-injury, by far. But once you give yourself 6 months to build yourself back up again, then you can start thinking about taking some risk, okay? Got it? All right, okay.
Fair enough.
When looking at Dr. Hannah's videos on his public YouTube channel, I saw that Elizabeth had also been given ketamine infusions by him.
It was October 1st, 2013?
Yes.
Yeah. I got a tetanus booster shot.
What arm?
In my right arm. Or no, left, sorry. And within a few hours, my arm was burning on
higher. What happened over the next 2 months, Lizzie?
It started to go full body. It just was going everywhere, and we were in and out of the hospital.
What hospital?
I couldn't figure out. Primary Children's.
In Utah, and then what else? What other hospital?
That was
Boston Children's Hospital?
Oh, yeah.
Who's ranked #1 in the nation in neurology.
I was out of school for a long time, and then we flew out to Boston Children's Hospital.
I had found out that Boston was #1, and I knew that they would be the one to help us figure out what this was. And in fact, going against every doctor's recommendation on the ketamine infusions when discussing it with Boston and with some of the doctors back home after we had the diagnosis, highly discouraging me away from it. But I just knew that it was, followed my instincts, knew that it was the right thing, had been praying about it, kept researching, and it felt right. So we came out the beginning of February of 2014 and had a 4-day high-dose ketamine infusion with Dr. Kirkpatrick. I had to carry her to the bathroom, I had to carry her around places. She didn't sleep, she wasn't functioning, she had no life. It took a few infusions, it took 3 infusions with Dr. Hannah.
Mm-hmm.
And that night she's like, it's gone. I don't burn anymore, it's gone. We had a couple weeks of infusions that we did with Dr. Hannah. It was, I think, seven infusions. And it was finally the magic number.
When looking at Dr. Hannah's videos, I also saw that Bella, Elizabeth's sister, had become a patient of his, having 5 ketamine infusions at the point the video was made.
Hi, my name is Bella, and I'm 10. And I have CRPS. I got it from an ankle injury, and we were outside, and we were playing basketball, and then I fell down, and and that's how it happened. Then we flew out to Florida, and we got ketamine infusions, and it helped, and then it came back up for a second time, and so we did the same thing, and
infusions again.
And then the third time, we came out. It came to remission in 2 days, and it feels like there's a bunch of barbed wire going into my skin, like epileptical.
The CRPS?
Sort of. Yeah.
It feels like what?
Like barbed wire, like going into my skin. And the first time it was in my legs and ankle, and then the second time it was in my leg and my arm, and now it's in my leg and my arm again.
And then what did we do to fix that?
We went to go get ketamine infusions from Dr. Hannah.
And how do you feel now?
I feel better.
Walk around. Can you stand up and show that you can walk? She couldn't walk because when it hits the legs, it makes them wheelchair bound. And so, carrying her, you go back, back and forth between carrying her around the house, carrying her to the bathroom, and, trying not to touch the areas that are sensitive or it's going to amplify the pain. And, she'll just, she just would scream in the beginning when she first got this, that she felt like she was being stabbed over and over again. And, we spent some time at the Children's Hospital going in and out, and I knew what it was because we had dealt with this once before with her older sister Lizzie. So, and the scariest part and most frustrating part was trying to get it diagnosed, trying to go through that process. Meanwhile, my daughter is being tortured 24/7 with the worst pain, and I knew what we needed to do. I knew where we needed to go, but we had to follow a process. We had to follow a protocol. And I think that was the hardest part. Once we got the approval for the ketamine infusions, Dr. Hannah got her in the next day, so we flew all night to Florida, drove here for the consultation, and she started infusions that next day. So the first time we did the infusions with this sweet little girl, it took 6 infusions. And she's like, it's gone. The pain's gone. It's not stabbing me anymore. And then we came out again a couple months later. She came back out of remission again. We call it, we're hitting some bumps. It woke up. And she had 3 infusions last time. That was the magic number then. And this last time, it took 2 infusions. So it was midway through her 2nd infusion. She's going, Mom, it's gone. I don't hurt anymore. It's gone. And it was the magic number then. Those are always the unforgettable words that I hear when it's gone, the relief. And her sparkle's back. She's happy again and able to walk and function again without the infusions. There's absolutely no hope.
Dr. Hannah helped me get better, and he got me into remission.
Oh, he's been amazing with Bella, and with Lizzie too. He's just so caring, so compassionate, and he just told me, after flying all night, he's like, it's okay. He says, I'm gonna take care of her. She's gonna be okay. And every day he would, come into the room and say, it's okay, she's gonna be okay, because it just kept one infusion after the next. And this is my little girl. She's 10 years old, and we had already done this once before with her older sister. So getting hit with this twice was devastating, and he understood that. He understood it. I feel like he doesn't view my children as patients. He views them as almost like they're his own, and he's even said to me, she's mine too. So it's pretty incredible to know that you're loved, you're taken care of, and and even with this one in particular, Dr. Hannah is very protective over her. It's cute, very sweet. So we're really grateful to Dr. Hannah and his entire team here. So keep doing what you're doing. Thank you.
When doing research for this video, I saw that Elizabeth and Bella's mother sued the makers of a vaccination for causing Elizabeth to have CRPS. She was then awarded $104,000. So, that is a review of Dr. Kirkpatrick. He seems very central to the Maya Kowalski case, as he was the person who diagnosed her with CRPS when all the doctors before him said her presentation was in the somatic symptom and related disorders category. In that regard, I found this exchange between the Kowalski attorney and Dr. Chopra interesting.
Is there a problem in medicine with a diagnosis taking on a life of its own, otherwise known as a narrative?
Yes, it's a major problem. What happens is that one physician, maybe depending on his competency, incompetency, makes a diagnosis without any basis, and then that gets populated into the medical records, and then after that it's just passed on forever because no one wants to change that.
As noted earlier, another turning point was Beata learning about Jessica. The next section tells Jessica's story. It is taken from publicly accessible blogs, Facebook pages, and YouTube videos. Jessica's story has been included because I cannot help but notice similarities between Jessica's words and what Beata says in her blog posts, where she writes as if she was Maya. I will come on to those posts later. It is also striking to me that within a few months of Beata learning about CRPS, Maya is placed in a ketamine coma in Mexico, just as Jessica was, also being at the hospital at the same time as her. I will begin Jessica's story with clips from Dr. Kirkpatrick's assessment of her in 2009.
Okay, Jessica, here it is. It's August 3rd, and you're here to be evaluated for the ketamine coma study. So now let's go and see what you can do and cannot do in terms of function. I want you to take that right hand and put it behind your head, please. Let me see how far you can get without torturing yourself. Is that as good as you can do? That's it? All right. Now you did the try, then go ahead and put it back down again. That's fine. Put it back down if you want, or you can leave it there. That's fine. Now do the same with your right side.
With my left side.
I am, excuse me, your left side. You have more movement there, don't you?
Yes.
Yeah. Okay. So you can do a little bit better with that side. Now the next thing I want you to do, on that especially on the left side of your face, it's very tender, isn't it?
Yes.
So I want you to take your hand over there and I want you to push on it till it starts to tingle a little bit when you push on the side of your face, so we can see how hard you push to get the tingling. Now push to where it's painful so we can see how much pressure is required to have it painful. That's painful? Yeah. Okay, that's good enough. Good enough. I want you to open and close that hand as quickly as you can using your thumb. Have your thumb do some movement there too. That's the best you can do?
Yes.
Now I want you to do the same thing with your left hand. See how well you can move that. You can do better. So far what we've documented as far as function is concerned, you're far worse off on your right side, correct?
Yes.
Okay. Try to rotate your ankle for me. Can you do any rotation there at all? Can't really. How about wiggling your toes on this side? Can you wiggle your toes at all? No. You can't do that. How about over here on your left side now? Go ahead and wiggle your toes over here. I think you can get some movement over there, right? That's it? How about rotating your ankle? You want to try and do that? I'm thinking, I can't think of anything else right now. I just know that she's probably one of the more debilitated individuals that we're going to have to deal with here. What's happening here, Jessica? You having a cramp or something in your leg on that left side? A tremor?
She gets these left side tremors. Sometimes they can get even worse and sometimes go into a seizure.
I get seizures, my back goes up.
Now, you realize this is a study, right? It's not a treatment.
Right.
You have certain obligations to be in the study. And one of those obligations is to allow the doctors, including me, Dr. Schwartzman, and Dr. Cantu, to accurately follow up on what kind of clinical response, whether it's bad or good, okay? And we talked about the study. When we have patients like this, we have to tell them, quite honestly, you may not wake up from this. You know that, right?
Yes.
What do you think of that? Are you willing to accept that kind of a risk?
Yes, because right now I can't do anything. My life is gone. I mean, I can't even watch TV or talk with friends because of the light and the noise sensitivity. I'm in so much pain day in and day out. And as far as I'm concerned, I don't have a life right now. So
right.
It'd be no difference if I died.
Jessica also had a blog, which she and family members would add to. In one post, her mother wrote, "Jessica has been treated with multiple pain medications at the highest possible dose, as well as an implanted dilaudid pain pump. Many doctors told us that the amount of medications Jessica was taking would be enough to kill a horse. Yet they have very little effect on her. Dr. Kirkpatrick is recommending the only treatment available that can possibly put her in remission, the ketamine coma procedure, a clinical trial that is being conducted in Monterrey, Mexico. Yes, this is a radical, scary treatment. However, for Jessica, scary is thinking that she could spend the rest of her life in this condition, unable to walk, eat, or take care of herself." This blog post also includes a photo of Jessica being lifted by stretcher into an air ambulance. The next set of clips are from a 2013 news report.
Tonight, a Four in Your Corner special report, an agonizing life or death decision. A young woman in Naples in such torturous pain, she begs her mother to let her die.
I couldn't get out of the bed, I couldn't eat, I couldn't move. Every single thing in my life was pain. Any type of lights or sounds triggered a seizure.
Desperate for answers, the family took Jessica to more than 100 doctors all over the country.
And we're gonna keep fighting.
That fight took them to the RSD Treatment Center in Tampa, where Dr. Anthony Kirkpatrick suggested Jessica's last hope for survival was to become part of a research study in Monterrey, Mexico. There, Dr. Fernando Cantu would attempt a drastic experimental procedure not approved in the United States. Jessica would be put into a coma using an anesthetic and hallucinogenic drug called ketamine. They would pump more of it into her body than an American hospital uses in an entire year.
It's a really radical, risky treatment.
And that's the part that sounds scary.
Exactly. I mean, it is. You can die.
Really, we were told she would probably die there in Mexico.
Jessica spent 7 days in an induced coma, nearly 3 times as long as allowed in the U.S. But serious complications followed.
I didn't know who I was. I had complete amnesia. I didn't recognize my mother. It was just like my whole life had been wiped out from this coma.
The nightmare didn't stop there.
And I ended up losing my eyesight. The hallucinations were terrifying.
What was expected to be only a few months of treatment in Mexico turned into years. She nearly died several times.
I was on a heart machine, on a breathing machine, being fed through a feeding tube, and I just asked her, please, just shut it. Just shut everything. I can't do it another second. She said, no, I'm not God. I can't decide when that time is for you. And as long as there's still life in you, there's still hope, and we're going to keep fighting.
Doctors tried again, this time using a different anesthetic drug to induce a coma. Jessica's health slipped into a free fall. Her lungs collapsed. She was dying. To save her life, Dr. Cantu would pump her full of ketamine once again, putting her into her 3rd coma in 2 years. She was in critical condition. Her battered brain and body were less likely than ever now to survive.
God is an awesome God, isn't he, Jess?
Now 24 years old, Jessica uses a wheelchair as she transitions from years of being bedridden far from home.
The next set of clips are from Jessica speaking at a Lutheran church youth gathering in 2013.
I couldn't do anything. Even turning on a light, listening to music, or looking at a computer caused me to have a seizure. Through a series of events that only God could orchestrate, we found hope. I never could have imagined that God would choose Monterrey, Mexico, and that he would choose to use Dr. Fernando Cantu as his healing hands. We were told there was one last option that could save my life. An experimental research study, not approved in the U.S., being done down in Monterrey, Mexico. There was no guarantee it would work, and we were actually told I would probably die there in Mexico. As scary as that sounds, I felt no fear. I had no life. Anything would be better compared to the hell I was living. Death would even be a welcome escape. I started running a high fever and was rushed by ambulance back to the hospital in septic shock. In my desperation, I asked God to take me home. I told him I was done fighting. I was ready. My lungs had collapsed and filled with fluid. Every breath I took felt like 1,000 knives piercing through my chest. But while I lay there, more dead than alive, God performed a miracle. 8 days later, I shocked everyone in that hospital when I awoke on my own, singing. God reached down and mightily saved me.
Jessica seemed to be doing well. However, in 2014, she wrote, I found out I would need to have surgery. The plan was that I would go down to Mexico, have surgery, and come home. It ended up becoming 4 months of numerous hospital stays and 3 surgeries. But by mid-October, I planned to fly home. She then wrote, I ended up back in hospital. Turns out I was in the early stages of sepsis. Somehow, my mediport in my chest got infected. She also included a photo. Next, she wrote, finally, my fevers broke and it was safe to implant a new port. Jessica then noted, my veins are incredibly difficult to locate. Dr. Cantu felt safe to do this surgery, but a vascular specialist should be in the room. What they ended up finding shocked them. Most of the large major veins leading to and from my heart had blood clots in them. Several veins were blocked. In August 2015, Jessica wrote, months ago, I found myself back in a place I'd hoped to never be again, in the ICU, fighting to survive. Multiple surgeries over the past year and a major sepsis infection caused an RSD relapse to hit my body hard, and I was medically in worse condition than when I first came to Monterrey back in 2009. This photo is from Beata's blog, showing Maya and Jessica in Mexico together, around Thanksgiving of 2015. It is unclear if Jessica returned to Florida and went back to Mexico. As a few years later, on 26 June 2017, a family member wrote, I mentioned how Jessica was beginning to get only a few lesions on her left knee. Due to the sepsis infection, this has turned into over 50 bleeding, burning sores over her entire leg. In order to try and get these lesions to stop bleeding and spreading, Dr. Cantu has been giving her ketamine infusion treatments. The plan is to continue doing these treatments 3 times a week for the next 6 weeks. On November 9, 2017, Jessica then wrote, 7 months ago today, I was wheeled into the operating room to have my right leg amputated to save my life. A year later, in December 2018, her mother then wrote, It is with heavy hearts that we are sad to say that our beautiful Jessica went to be with Jesus 2 days ago. She fought a long, hard battle. But in the end, multiple infections, which eventually led to sepsis, were too much for her body to overcome. During the trial, Dr. Cantu was asked if he has lost a patient or knows a patient who has died from CRPS. These clips are from his reply.
Has he lost patients, or does he know of patients who have died from CRPS without treatment or with treatment?
I met a patient
que ella vino al coma.
Who came to coma. She was 3 years out with a completely normal life.
Pero luego tuvo un relapso.
But then had a relapse. After that, she had a fall from her bed.
Se fracturó una pierna.
Fractured the leg. There were then no resources to continue treating her the way she had been treated prior to her problem. Progressively, she lost the ability to feed herself. We had to use with her IV analgesics for pain, and she finally passed.
It is unclear if Dr. Cantu is referring to Jessica Stevens, as he does not mention an infected port, sepsis, or blood clots. Andrea Giannopoulos is reported to be another patient who died at the Hospital San Jose in Mexico, where the ketamine coma study was being conducted. Andrea founded a nonprofit organization named Fighting for Us, which focused on supporting those with CRPS. It is stated that she first participated in the ketamine coma study in Germany and was planning to return. On January 18, 2009, she then shared, "I will not be going to Germany, but now I'm going to Mexico." Reports state that on February 11, 2009, she then died unexpectedly at the hospital in Mexico. She was just 26 years old. My research indicates that some patients treated by Drs. Kirkpatrick and Hannah have taken their own lives. This raises my concern about some individuals with somatic symptom disorders being diagnosed with CRPS and receiving ketamine from anesthesiologists, rather than the psychological and physical therapy they truly require. It's even more concerning to me if these patients are led to believe that mental health professionals intend to harm them, or that CRPS will lead to a slow and painful death without higher and higher doses of ketamine. Also, the long-term effects of ketamine, especially on the cardiovascular and gastrointestinal systems, remaining unknown. Part 2 covers this further. Part 2 also includes more videos from Dr. Kirkpatrick's assessment of Maya, and continues the timeline up until Maya's admission to Johns Hopkins All Children's Hospital, including more blogs and emails. Part 2 also looks in more depth at ketamine, medical child abuse, and Munchausen's by proxy, as well as who Drs. Cantu and Dr. Hannah are, and the role Dr. Chopra played during the trial. It then concludes with a look at arguments out of the presence of the jury. Please click the link for more.